treating the uninsured population group is so hard because their medical problems are far more advanced because they're not seeing a doctor regularly. They're not coming to the hospital regularly. So they only show up in the hospital until something bad is really happening. And so they're very complex and very hard to manage.
My name is Ryan, and welcome to my channel, where I do things that I think are interesting. I am thrilled to kick off my first interview with a very special guest, a close friend who has been there for me and now dedicates his life to helping others during some of their most challenging times. Our guest is a hospitalist in Santa Barbara, California, and while I always knew he was a doctor, I never fully understood what his job entailed. This was the perfect opportunity to learn about the daily responsibilities of a hospitalist, the challenges they face, and to get a glimpse into the intricate workings of our healthcare system. Throughout this conversation, we touch on a wide range of topics that include medical misinformation, the financial implications of choosing a specialty, and alternative medicine. Since this is my first interview and an early attempt at podcasting, the audio quality is a bit different from what you're hearing now. Despite that, the content is packed with information and definitely worth a listen. With that said, let's jump right in and hear from our guest, Dr. Sean McGuinness. So let's start off. Just please tell us, what is it that you do?
Well, I am trained in internal medicine, but my term is called a hospitalist, which most people don't really understand what it means. I played around a golf today and told the guy I was a hospitalist, and he looked at me clueless and didn't even know that was a doctor. So I do inpatient medicine. Anyone that's admitted into a hospital, I would basically manage their care from when they show up to the ER until they leave the hospital. Kind of a jack of all trades.
What is it that people commonly think you do that they, might get wrong?
I think a lot of people assume that I'm a primary care doctor, so I work in the clinic or in the office only. We're kind of that primary care doctor in the hospital. So if you need a cardiologist, I'll consult a cardiologist or a pulmonologist or whatever specialist. I'm kind of running the show and coordinating the care with all these other providers, but I'm kind of like the quarterback, and I run your care, and then when you're ready to go home, I discharge you back to your primary care doctor or someone that's going to manage your blood pressure or your diabetes or your cholesterol that you're seeing once every 6 months or once a year. And if they find something that's bad, then they will get you into the hospital, and that's where my role comes into play.
Now, just by chance, do you happen to see people that you've seen previously?
Yeah, there's kind of our frequent flyers that are people that have every medical condition: heart failure, kidney failure, diabetes, and they are the rotating cog in the wheel where they come in the hospital, they leave the hospital, they come back a month later. So we do have a handful of those, but otherwise, I'm never seen these people before.
So you have your white coat on, you come into the room, you check up on me, say I need some blood work, and then you leave. What is it that you're doing once you leave that room?
There's a handful of different computer systems that we use in the hospital. We use one called Epic, which is the most popular, and it's basically a system of all the electronic charts. We don't use any paper charts anymore. When I see you, and let's say you have anemia or low blood counts, for example, and I walk out of the room, I'm going to go do a workup of that. So I go into this Epic system, into your chart, and I'll place orders. They're electronic orders that are going to trigger something to happen. So if I want to check your hemoglobin, your iron levels, I go in the computer, type iron, click the order, submit it. That then goes into the system, and that'll trigger a phlebotomist. They'll get a notification that says, I have to go draw blood on Ryan Dorman. And they'll walk into your room, draw your blood, send it to the lab, and now the order's in the lab. And the lab runs it. An hour later, it pops up into your system on the computer, and I get a little flagged notification that your blood is done.
So a bunch of IMs going back and forth while I'm sitting there just waiting and wondering what is happening.
And then there's a nurse involved, and I might be messaging the nurse literally by text message in our computer system. Hey, I'm checking Ryan's iron levels. I'll have the results in 2 hours. Or if I'm getting a CAT scan on you, I'll order a CAT scan. It'll trigger the radiology team, who then sends a tech to come wheel you from your room down there. The image goes to the radiologist, who writes in a description of your CAT scan. It goes in the system, and then I see that result there. So there's all these different people involved in the hospital, and everything's controlled by a computer, and I can just sit there and type in certain orders that I want, and it magically happens.
And I think we as people, when we go see the doctor, we tend to forget that you are a human. And, although you've done years of training and lots of experience, that there's things that can go by and amiss. And that's what happens. And I'm an engineer, and Just because I did all the schooling doesn't mean I memorized every single equation. I have to go back and look.
We look things up on a regular basis. We have this thing called Up to Date, which is like the Wikipedia or the Bible of medicine. And at least I'm regularly looking things up that I forgot or couldn't remember.
So you don't just graduate, have everything memorized, and move on out into the distance.
Far from it.
Speaking of having things memorized, mistakes happen. It's a part of being human. We make mistakes. Can you help explain like what are some mistakes that you see specific to your position or just in the hospital in general?
The most common way mistakes are made in my field are when the physician approaches the patient with a narrow mindset. And my older attending would always put his hands up, on the side of his eyes, like he has blinders on. The ER will call him and say, "Hey, I've got a patient with pneumonia." And so you walk into the room saying, "Okay, this guy's got pneumonia. My job's done." And that's where the problem lies. If you were walking down the street and you meet someone of a certain ethnicity and you're prejudiced against that person before you meet them, it's kind of the same idea. So really having to step back, meet the patient, talk to them, get a good history instead of walking into the room with this narrowed, focused mindset that you already know what's going on. I think that's where mistakes are commonly made.
That seems to answer why if you go to the doctor and you meet the first doctor, they ask you about your symptoms and you state it. Then you go see the second doctor and he asks you essentially what sounds like the same question. Your doctors are trying to really avoid having that mistake and make sure they caught everything.
Right. Yeah, we're trained on how to take a history from a patient, and there's certain questions we get good at asking. But I think some people, like if you're referred to a knee specialist for pain in your knee and that specialist already thinks he knows what's going on before you walk in the door, that's where problems occur.
What else do you do to try and prevent this type of mistake occurring? Like, is there something that you always try and keep in mind? Is there certain training that you guys have to go through?
I usually let the patient talk first. I try not to interrupt them too quickly. The more they talk, they can express really what's going on. There's some fact about doctors in general interrupt their patient after like 7 seconds of introduction, which is terrible. You should let the patient speak and voice their symptoms and their concerns.
And what happens in the case where you come across a patient who just is shy?
Oh, those are hard. Yeah. You get a lot of one-word answers and you keep prying and prying, but hey, it happens.
What are some of the most difficult parts of your job? I've heard that it's difficult to get patients out of the hospital for various reasons. Like, what have you experienced and gone through?
First off is complexity of care. So if I have a really sick, complex patient at 2 a.m, that's stressful. I might be managing 80 patients on the floor, so that's very hard. Also, personality types. So you might have a difficult patient that requests you give them this medication or order an MRI on their brain because they have a tingling in their ear. During COVID, there was the whole ivermectin phase, and people were requesting ivermectin or hydroxychloroquine, which there was very little evidence that it was beneficial. And I would get that all the time. Patients would request that I give it to them. So that was tough. And then I think the last thing you mentioned was getting people out of the hospital. So if I want to discharge someone from the hospital to a nursing facility or a rehab facility, then I need the insurance company's approval. I need a case manager who's the person that makes this process happen, set it up. And that could take days to a week when the patient's just sitting there ready to leave the hospital. I'm waiting for these other people to do their role before I can get them out.
So what you're telling me is that the doctor really is on your side at most times. They're trying to give you the best health coverage they can, and there's outside forces working that could be working against you. Speaking about the patients that come in that are almost demanding something, do you feel like the sources like WebMD, Google have prompted more patients that are misinformed or patients that do come in more informed?
I think it's honestly more Facebook now. People are on Facebook giving each other medical advice when they're not trained medical professionals. And then something like ivermectin pops up, and it was very political at one point and it blew up. And that's what happens. And then they show up in the hospital and say, "Oh, ivermectin works. Give it to me." Well, what's your evidence? How do you know this drug works? Was it in a clinical trial? Is there a randomized control trial with it? No, there's not, or there is now.
What would you say to these patients that have a firm belief in some of these practices and what they're seeing on Facebook? How would you try to quickly tell them how to spot the fake advice?
I would again go back to we do evidence-based medicine, meaning I only prescribe medications that I have clinical evidence that was in a clinical trial that will improve your outcome over a placebo. And if they disagree with me, then I would argue ivermectin or hydroxychloroquine have side effects, and I don't want to risk that chance of side effect like a heart arrhythmia or whatever it may be, that I give you a drug that's not going to help.
I know you go to med school and it does take time until you actually land on what you want to do. At what point was it for you that you made your divergence and decided to head in this direction?
The route is you do your 4 years of college, you then go into medical school, do 4 years of medical school. At the very end, you then apply for a specialty, which I did internal medicine. But during your 4 years of medical school, you're rotating throughout all the different departments in the hospital. So you're doing neurology, surgery, pediatrics, OB-GYN. And so you see a little bit of everything. But internal medicine is kind of the mentioned this earlier, is the jack of all trades. You know a little bit about every field, and I thought that was unique. That any patient that walks in the door, you have to manage whatever the problem may be. Whereas if you're a neurosurgeon, you're more specialized and really see only a minute portion of the population.
So it really sounds like when it comes to an apocalypse, I want to look for the internal medicine doctors and leave
Exactly.
the neurosurgeons behind.
Exactly. But neurosurgeons, oh man. So after you get into residency, so I did 3 years of internal medicine, then I'm finished practicing. Whereas if you then want to go to neurosurgery, it would be, I think they do 7 years of residency and then like 3 more years of surgery on top of that. So it takes them a long time to get.
Do you feel like the length of time kind of persuaded you into a certain direction?
Definitely. I mean, the other part of it is you're not making good money in residency. You're making, depending where you live, $50,000 to $70,000 a year while you have this huge medical debt. So you have 4 years of medical school debt. Then you go into training, getting paid 50,000 a year. And let's say you're doing neurosurgery, that might be 7 to 10 years that you're making that amount of money. And so it takes so long until you actually make the doctor's salary and start paying those loans. Definitely a reason why I chose internal medicine and just start working and start paying off loans.
What do you think it would take, or how would that benefit to bring down that payment to get in?
Firstly, there's a massive shortage of physicians in the country. If you want to see a primary care doctor, I know at least in Santa Barbara, it can take you a year to get an appointment. So there's definitely not enough. And I think the medical debt that we take on in medical school deters people from going into the field. I had friends that lived in other countries, like in the Caribbean, actually, that their schooling was free as long as they practiced in that country for a certain period of time, like 5 years. Theirs was completely paid for.
I did read recently that primary care physicians tend to be in a low supply, mainly because when you make your choice, you either be a primary care physician or you can do something like an orthoscopic surgeon and make a lot more money. And that tends to be a deciding factor too.
Yeah. Yeah, primary care gets paid the least out of any specialist, and therefore it's the least competitive of all. But in the entire nation, that's the specialty, the type of doctors we need and we're short of.
Well, let's talk about money. How do you get paid?
I'm paid on a salary and productivity model, which about 60% of all hospitalists in the US get paid off of this model, with a smaller fraction being salary alone. So we have a base salary of X amount, and then every patient encounter we submit a bill for that encounter. So if I see Ryan Dormand in the hospital today and I treat your pneumonia, your heart failure, your kidney disease, I then submit a bill of how complex you are as a patient. Am I ordering labs, interpreting radiology results, ordering diagnostic tests? Then I bill you either a 1, a 2, or a 3. If you're really complex, I bill you as a level 3. If you're medium, a 2, or not complex, I bill you as a 1. And so every day I might see 15 to 20 patients, and I submit a bill for each one of those patients.
Interesting. I could see how that might push some doctors to really try and see as many patients as possible. There's an incentive for you to try and treat as many as possible.
And how honest they are with their billing. Some physicians overbill, which is fraud, but it definitely happens.
So, what other billing aspects do you see that might be news to a layman like myself?
Time is another one. So I can either bill by how complex you are as a patient or by how much time I spend with you. And so you'll see a lot of doctors at the bottom of their note says time spent on this encounter was 70 minutes or greater. When that's a lot of time. When you think about spending 70 minutes. So those are your two options, or you can bill by complexity of the patient or by how much time you spend with them.
All I can think about next is how this interacts with my insurance company and how my insurance now talks back to you. I mean, I feel like this is part of the reason why it can be so complicated and trying to figure out how much it's going to cost for me to go see a doctor sometimes.
And the insurance company is looking at my note and they'll say, okay, he billed a level 3 encounter. Well, that means I have to have certain criteria in my note to meet that. So I have to have a 10-part physical exam. I have to examine 10 parts of your body. I have to have certain number of lab tests and radiographic images completed. I have to interpret the data. So all of those, if they're not met, they'll say, nope, he doesn't get that, that money for the bill, and they'll not knock it down. So there's a lot to it.
I really don't like insurance companies at this moment.
Me neither.
Oh, good to know. We're on the same side. I like that. Well, speaking of insurance companies, a well-known insurance policy is Medi-Cal. It's similar to Medicare, meant for low-income residents. California recently expanded their Medi-Cal services to include undocumented immigrants between the age range of 19 to 49 years old. Therefore, now Medi-Cal can service all ages of undocumented immigrants as of 2024. It's expected that at least 700,000 people will now utilize this new healthcare coverage. What is your general opinion on expanding our Medi-Cal services like this?
Well, I think, it's pivotal to have healthcare for everyone in the country. That's first and foremost. Everyone should have access to healthcare. If you look at other countries like Canada, for example, Canada is the same scenario. Everyone in Canada has access to healthcare coverage or insurance. The problem that I see in Canada and we see here is then when you want to see your doctor in Canada or get a procedure done or an ultrasound, it takes so long to get anything done because everyone has free access. So they're just taking advantage of the system. They're going to go get a chest x-ray because they have a minor cough when in reality you wouldn't have gotten that chest x-ray. So the issue with providing access to everyone in the country is we then don't have enough resources. We don't have enough physicians, offices, hospitals to provide care for that many people. Stepping back, everyone should have access to healthcare, but then we need our healthcare system to ramp up to be able to take care of that many people.
And I think that really circles us right back to where we started when we were talking about how expensive it is to become a doctor, and that in itself is a limiting factor to us possibly having more physicians to take in more patients. What type of experience do you have dealing with, I'd say, Medi-Cal patients directly, if any?
So when you're in your training, in your residency training, where you're an MD, but you're kind of practicing under supervision in the hospital, you take care of the uninsured or the Medi-Cal patients, and that's how it works in the country. Is the uninsured go under the care of the training residents. So for 3 years, those were the people I saw, and they're very difficult. Now that I'm working for a private group, I see only insured patients. Back then, I saw only uninsured patients. So it's kind of two different populations of people. And I'll tell you, treating the uninsured population group is so hard because their medical problems are far more advanced because they're not seeing a doctor regularly. They're not coming to the hospital regularly. So they only show up in the hospital until something bad is really happening. And so they're very complex and very hard to manage.
And I really want to stress that point that when you don't have medical insurance and you don't have access to coverage, that you really aren't going to go seek it until, like you said, when it becomes an emergency. And at that point, what are the options for care? Can you give us some examples of these patients and what type of diagnoses they had?
Again, kind of the same main issues I'm seeing. People that would have diabetes that's been untreated for years. And so that diabetes has led to their kidney function declining, their eyesight declining. They develop heart failure, and they literally show up in the door without having seen a doctor in 10 years with their kidneys are failed, their heart's failed, they're partially blind, and you're just having to pick up from scratch, having no prior information. So that's what's difficult. All the preventative care that you and I would normally get, they don't have because they don't have a doctor. They haven't been seen by anyone. So they fall through the cracks. Their health declines over years, and then they show up in really bad shape.
But how do you anticipate that an extra influx of the 700,000 expected people utilizing this system and healthcare coverage in California, how do you anticipate that's going to impact your industry, your profession, maybe either locally or even statewide?
So a big part of it is someone that's uninsured, the ER can never say no to a person. So if you're an uninsured patient that has a medical problem, you go to the emergency room and it gets handled. If you have insurance or you have Medi-Cal, you then have the ability to go see a doctor, a routine primary doctor, get your blood work checked every year, do a physical exam, pick up that problem before it happens, get you on blood pressure medicine, cholesterol medicine, preventative techniques to prevent those problems down the line. So I think by expanding Medi-Cal to all these people, they now have access to healthcare, and we prevent their diabetes from getting out of control. Right now, those uninsured people, they don't have a doctor. They have a problem, they just show up in the emergency room. So now our emergency room is overloaded. They can't handle the amount of patients. So I think actually a good part of the Medi-Cal is we take the burden off the emergency room and start doing more preventative medicine.
This latest expansion is, I think, just one small step closer to that goal that a lot of progressives want, which is single payer healthcare. What other benefits or concerns do you have about moving into that system?
I just don't think we have enough, doctors, hospitals, offices. We need to expand our healthcare. And again, Canada is a good example. It takes twice as long to get anything done in Canada than it does here because they're just overburdened.
Where in our system do you think would be most effective to make a change for, I guess, your best results? Like, where would you like start with if you could, just wave a wand and go with it?
I think we need to pay primary care doctors more money than they get because that's where the problem is. If we had better access to primary care, we would have a healthier population. We would prevent people from getting sick and going into the hospital. And so I think that's the answer truly. There was a study in the Lancet, I forget what year this was, but the wealthiest 1% of women live 10 years longer than the poorest 1%. And the wealthiest 1% of men live 14 years longer than the poorest 1% of men. So I think it says a lot about their access to care, also quality of living, but definitely their health care. That same paper, though, looked at, so was it, I think 36 states have expanded Medicaid, and the states that expanded had 11 to 12 fewer deaths per 100,000 adults from any cause.
So it is showing promise that, hey, expanding coverage of healthcare is saving lives.
It is. It is. And the other part of this puzzle is there's a lag time. So when I suddenly wave a wand and give you healthcare, you're not instantly going to be healthier, right? It takes time. So you then go see a doctor and get put on a statin drug, reduces your cardiovascular risk. Well, that could take 2 to 5 years. Or your doctor gets you a colorectal screening or a breast screening to prevent cancer. That could take 3 to 5 years to have an effect on improving your quality of life. But just this expansion of Medicaid, it's going to take 5 to 10 years before we see the outcomes. A couple other fun facts. There was a poll. Guess what percent of Californians supported expanding health insurance to undocumented immigrants?
Oh man, I hope this doesn't make me sad.
No, I was actually surprised to see the number.
All right, if you're saying you're surprised, I'm gonna go in with 70%.
It was 66%.
That's pretty good.
And then, okay, one other thing. What is the income to qualify for Medi-Cal in California? This is a family of 4 to qualify for Medi-Cal. What is the income limit?
I think the top income for Medi-Cal family of 4, 40,000.
$41,400. Family of 4. That's not a lot of money.
No, so I mean, and people will harp on Medi-Cal being like a waste of money. Like these are people who are struggling that, look, 40,000 in California doesn't get you very far. I'm happy these people have access to medical coverage. I would scream at the mountaintops that they have medical coverage, and I hope we continue to expand this. Let's get this right back to you. I think it's common now, what you'll see on social media, people talking about being holistic and having a broader view of what health really means. And we can talk about Western versus Eastern medicine. How much truth is there that Western medicine predominantly treats just symptoms as opposed to a holistic treatment and prevention care?
So this is a big topic. Eastern medicine, or that term, is basically all of the different types of medicine that arose from Asia. And that's been around since, 5000 BC. This has existed forever. It wasn't until around the 19th and 20th centuries that we actually had an advancement in science. So we started coming up with things like germ cell theory, clinical trials, antibiotics, and that's where science diverged from Eastern medicine, and we now call that Western or modern medicine. We start learning how to do clinical trials to prove that things work or don't work, and that's kind of the divide of Eastern and Western medicine.
From this divide, how is that taught and approached during your training?
So my training is focused on a really important term, evidence-based medicine. So things that have been through clinical trials and proven that something works or does not work. The world of alternative medicine or Eastern medicine, they're not really backed by evidence-based medicine or clinical trials. And I think that's the big problem and the big divide between the two. So at least in medical school, we're not learning about acupuncture. We're not learning about Tai Chi. We're not learning about these other things because there's no randomized clinical trial to prove that Tai Chi is a form of treating osteoarthritis or whatever example you want to use. And so for that reason, it's kind of left out of modern medicine per se.
Do you feel like there's any validity to actually some of those practices?
For acupuncture, for example, or all right, that's a hot topic. We can mention it. Thus far is no evidence that acupuncture is effective. There are a couple trials where they it's called a sham trial, where they did the acupuncture in half the patients. The other half of the patients, the needle had like a cover to where it wouldn't actually pierce the skin, but the patient would think they're actually receiving acupuncture. And then they measured the two groups before and after if there was a difference in pain or anxiety or depression, and there was no difference.
What do you think it is that drives people to look at these type of alternative solutions to their health?
The reason people buy into this is it emphasizes a natural mode of healing. So people say, oh no, I want a natural herb, I want a vitamin, I want something natural. They have a distrust with conventional medicine and think that taking something natural is better. Maybe it gives them some more autonomy over their care when they can pick and choose what they're putting in their body and think taking something natural is better. It's easily accessible. So you can go to a vitamin store and buy all kinds of vitamins right off the shelf without any prescription. And then also they'll see something on the news or on Facebook where a celebrity is promoting this weight loss supplement. They're going to be like, oh my gosh, if Gwyneth Paltrow is suggesting it, it's got to work. So I'm going to go buy it.
I think what that means is that we need a celebrity doctor out there who's actually spewing some truth.
Yeah, like what's his name? Dr. Oz, biggest piece of shit.
I got some other miscellaneous questions for you. How come doctors are notoriously late to their appointments?
You're the patient and the doctor's late to come in and see you.
Oh yeah. It seems like it happens every time.
It's because they're overbooked. Might have 30 patients in a day and might have 30-minute window to see each patient and then write their note and then go review the next patient. It's overbooking. That's what it is.
Tell me a little more about who your primary care physician is.
I took whoever was first available. I know him personally because he's in my group, but for me, it didn't matter a whole lot. I know what they're doing and I can kind of guide things that I'm looking for, things that I want done, and didn't make a difference to me.
Sounds like you do a lot of self-diagnosis. How do those appointments work out?
No, I'm healthy, but I can, doctor, I think you should check my liver test. It's been a big drinking month for me. Let's make sure those liver numbers are okay.
Do you have any fictional doctors that you're a fan of?
Dr. House was always my favorite. And I'll never forget on my board exams, I actually got a question right on my board exams due to an episode on House. It was a type of pneumonia acquired by birds. And one of the episodes was these people in bird fighting and someone picked up a pneumonia. So that's why I always love that show.
Are there any doctors out there that are currently working, or maybe they retired, or even have passed that you've idolized or found as a favorite?
There was a Dr. Hosea when I was doing my training who's actually still in the hospital, and he's kind of the person I call when there's a case I can't figure out. He was also kind of like the Dr. House, been doing medicine for 40, 50 years and was just this all-knowing, wise old doctor that everyone went to.
We're going to end off this session with your initial reactions to the following words or phrases. And I'll start off: medical conferences.
Love them. Learn a lot.
Electronic health records.
Pain in the ass. Takes a lot of time out of all of our day. And we get messages constantly from billing, coding, all different people saying we're doing our job incorrectly.
Wow, you have a lot to say on that one. All right, moving on. World Health Organization.
What's the starship in Star Wars? The big main starship. Anyway, that's a bad example.
The Death Star?
Maybe the Death Star was what I was thinking of.
I don't know how I feel about that one. All right, next one. WebMD.
Does that still exist? Is that where you go online and type things and they give you medical advice?
That's the one. Yep. Next one here. Fauci.
I love him and I feel bad for him from what happened and how much crap he took during COVID. He was really brave and honorable for what he did.
Grounding.
Grounding? What do you mean? Like grounding a child?
Earthing? Does that help?
Earthing?
Okay. Do you mind taking a look at this?
Gets me excited. I'm like, hell yeah. Maybe I can help this person with a knowledge set that I've acquired over many years.
Dave Roberts.
Similar to Fauci, he has gotten, I think, too much crap from the people when I think he's done a good job.
For those that don't know, Sean McGuinness here is a big Dodger fan. Pretty sure lifelong Dodger fan.
Quite a few years.
Well, Sean, I'd like to thank you for being on this show. At this time, anything that you'd like to promote, plug, recommend?
2 books here. First one is called Do You Believe in Magic? And the subtitle is Vitamins, Supplements, and All Things Natural, A Look Behind the Curtain by Paul Offit. And it's basically kind of a look into the world of alternative medicine, naturopathic medicine, homeopathic medicine, this whole world, and really kind of removes the curtain, per se. And then I'm throwing out one more book here because this was awesome. It's called Zero Fail, The Rise and Fall of the Secret Service by Carol Leonnig. Basically tells the history of the Secret Service, how they came to exist, and goes through each presidency and talks about near assassination attempts or how the Secret Service helps President. Really good read.
I love it. I haven't read that one. It sounds like I'm going to have to read that, bring you back on, and we can discuss that book.
Okay. Well, thanks for having me. This was a good time.
Well, thank you, Sean. Appreciate it, and hopefully we get to talk to you soon.
All right. Bye bye.